Hi, guys. I'm here to talk to you about Chapter 7, Anxiety, Anger, and Depression. We are actually going to go through the entire PowerPoint. I will try to do that in a way that is relatively brief, but answers the questions that I think you might have. Okay, so let's get rolling. Okay, so here are the topics: anxiety, anger, depression, positive mental health. By the way, before I get too far into this, I am not going to pause for you to write notes, I think for an obvious reason, which is that you can pause the recording at any time. So I'm just going to keep on going. All right. Okay, so anxiety versus fear. This is a very important distinction. Fear is the emotion that we experience in response to a concrete danger. So, you know, if you have a close call while you're driving, you're going to experience fear. But anxiety is what happens when there's a feel of impending threat. And that can be very broad. It doesn't necessarily have to be something that that might happen, you know, in a reasonable, logical world. For example, you know, after experiencing that event in the car that caused you fear, you might become anxious that, you know, somebody might drive through your, you know, front living room window. That's certainly a possibility, but it's a very, very remote possibility. So, you know, that sort of kind of impending threat is what anxiousness is about. So both of these are related to the flight component of fight or flight, and we will talk about flight a little bit later. But if the anxiety, remember the impending threat, is kind of over the top and it causes a problem, and there's not a physical cause. Okay, so this is important. So, you know, you don't have a brain tumor or something like that. You might have an anxiety disorder, right? So there's a number of anxiety disorders. Generalized anxiety disorder is sort of an experience of anxiety that isn't tied to any one particular thing. It's not a phobia, which we'll talk about in a bit. But, you know, generalized anxiety disorder is exhausting. I mean, generalized anxiety disorder is kind of being in this constant state of high alert, and it will make you tired in a hurry, but also you're really tense. So, you know, it's very difficult to kind of get any relief from it unless you're being treated. So 5.7%, I like to think of percentages, not so much in terms of the percentage number, but in terms of per 100 or per 50. So, you know, this is like 10 people in every 50 people. That's a lot of people, right? So you can often see this sort of thing developing in childhood or adolescence. I can talk a little bit later about how you might avoid the full-on development of an anxiety disorder, really any disorder, but that's by no means a promise. You can't always avoid it. So when we get to the diathesis stress model of illness, we'll talk about that a little bit. So generalized anxiety disorder, as with all anxiety disorders, symptoms are exacerbated by stress and come and go kind of throughout your lifetime. But more or less, once you've got it, you've got it. Okay, so panic disorder. This is kind of like it is in the movies. You know, this is sort of your classical panic attack. If you've ever had a panic attack, it is really, you really do think you're going to die. Most people who have had panic attacks are fearful of having more panic attacks, and sometimes that can cause panic attacks. It becomes kind of a big mess sometimes, but there are medications for this. They don't always work, but there are medications. Okay, phobias. So the one thing I really want to highlight about phobias is that the definition of a phobia is that it's an unreasonable or excessive fear of an object, situation, or activity. Okay, if you are in the pen with the lion, that's not, the fear that you're feeling is not a phobia, because that's a perfectly reasonable fear to be having. You know, the phobia would be, I can't even walk by, you know, the lion display in the zoo because it makes me so anxious, right? So the categories for phobias, you know, kind of the broad categories. There are a lot of phobias, but agoraphobia, social phobia, and specific phobias. So, you know, the lion example would be a specific phobia. Okay, so OCD. The thing that I really want to highlight about OCD is the difference between obsessions and compulsions, and that they can occur separately. They do not have to occur together. So I think we often think that they have to occur together, and they do not. So obsessions are the thing that's happening in your head, and the compulsions are the things that you do. And absolutely, you can obsess over something and not take an action about it. That would be a compulsion. And also, and this is less common, but it definitely happens, there can be things that you do in a repetitive, compulsive way, but it's absent of thought, right? So that's, like I said, less common, but it absolutely happens. My advice to you is that if you see this, especially compulsions, developing in a child, get help immediately. The earlier it develops, the harder it is to deal with it in adulthood. So, like, if you are like, well, you know, I started compulsively doing the light switch when I was 5 years old or something, and now I'm 30. That's very, very difficult to deal with. But if you get treated early, then you can have a very different type of outcome. So OCD is pretty rare. It does, you know. I also want to be really careful about this, because everybody experiences obsessions and compulsions at some point, especially young people. So, like, before our prefrontal cortex is fully developed, we can act obsessively. You know, like I'm thinking specifically about, you know, behavior towards significant others and stuff like that. But where it becomes a disorder is in general, disorders are when they start to interfere with your life, when you can't do other things, like that sort of stuff. So, you know, don't think that, oh my God, I have a thought that I can't get rid of. I had to check the alarm clock 5 times or something. Like, you know, to a certain extent, everybody has some mild obsessions and some mild compulsions. The question is, how disruptive is it? That's what draws the line between normal behavior and disorder in general. Okay, so PTSD. PTSD is way more complicated than you can see on the slide. So I am putting up some videos about PTSD that I really want you to watch. It looks very different for different populations. So PTSD often looks a certain way for combat veterans. Looks a different way for survivors of sexual abuse, like that sort of thing. It does not look the same for everyone. And so sometimes it can make it difficult to diagnose. And also the criteria for PTSD is very broad. So, that can make it complicated as well. But this slide is a pretty good, really general bucket. The thing that I am a little wary about is this first bullet here, this re-experiencing the traumatic event. Yes, but I think we often think of that in the Saving Private Ryan sense, that people are actually having literal flashbacks. In my experience, not everybody has a literal flashback, but that doesn't mean that, when the fireworks go off, that they don't think about the mortar, right? So re-experiencing has a broader definition than you think. Avoiding stimuli related to the event, to kind of take that example and move forward with it. If you are a combat veteran and you have some trauma around mortars falling, chances are you are not going to go to a fireworks display, right? And general response numbing. So just sort of in general, you go through life a little disconnected, and at the same time, this increased persistent arousal, so you're a little bit on edge, right? So you're disconnected, but you're also a little bit on edge. It's not a great combination. It does have a very high comorbidity with other disorders. I think that makes sense if you think about it. If you are living with these experiences, your chances of living with other mental health consequences of that, or of trying to self-medicate, so alcohol, drugs, that sort of thing, very common. I just want to point out that this prevalence rate might be low, right? So, first of all, it feels high to start with. So again, we're talking about 14 people, for every 200. I think I said 50 before. That's not what I meant. So it might be low because it's very difficult to get everybody, because not everybody seeks treatment, right? So, okay. So treatments for anxiety disorders. So there are a number of treatments for anxiety disorders. Medication, obviously, is one. The thing that I want to point out is that medication treatment for anxiety disorders is moving beyond just the Ativan of the world that we're all kind of used to seeing and dealing with. There's some really interesting emerging work around PTSD and MDMA. I will post a link about that. But also, cannabis does not have the same sort of addictive properties that some of the anti-anxiety medications do have, and can be very effective for some anxiety disorders. We need a lot more research about that, but many people have discovered that already. So, and for what it's worth, we have a program for cannabis at CCSF. Check that out. Okay, other treatments. So behavioral, the most effective type is exposure therapy. You guys actually saw a little bit of this in your last exam. So what I asked you to do, one of the questions was, kind of do a progressive exposure, and it works. It absolutely works. It is not that complicated to do. You need to be thoroughly trained in relaxation first, or it's going to be a huge mess. So, you have to be really, really good at kind of kicking into that relaxation response before you start doing the exposure therapy, right? Okay. So for OCD, response prevention, so like, I really want to hit the light switch, I really want to hit the light switch, I really want to hit the light switch, but they don't, right? So response prevention actually does work. Just being the therapist and like not letting that happen actually does work. It's difficult. It's more difficult than it sounds, but it does work. CBT, cognitive behavioral therapy. It is a evidence-based treatment that has a very defined structure to it. and it is designed to challenge the thoughts and the assumptions and the beliefs. It is really very effective. And what's really cool about it is that because it's so structured, it is time limited. It has the potential to be very cost effective. Okay. So anxiety management. So, you know, obviously there's more to anxiety management than medication and therapy. And you guys are already kind of working with some of this stuff. You know, this is part of what your wellness group is about, you know, is to try to get really into stress management, anxiety management, that sort of thing. I feel like that's especially important now in COVID times, and it is not very easy or practical or safe for everybody to go out and to, you know, get into an office and do traditional therapy. You know, we have a lot of work that we need to do on our own. So that's what some of the stuff is for. Okay, so anger. All right, so anger, as promised, you know, this is the flip side of your fight or flight. We just did flight, and so we're going to talk about anger now. And you know, I know that the bullet says that anxiety can supersede or accompany anger. In my experience, it tends to accompany anger. And like, you don't necessarily feel them in the exact same moment, but you they come very close, right? They're right up next to each other. So, you know, we've all felt anger. We know why we might feel angry. So, you know, what I want to cover in this slide is not sort of like the standard anger that we are used to dealing with, but like kind of the disordered type of anger, right? So anger in, anger out. So anger in is obviously what's directed towards yourself. Anger out is what's directed towards other people. They are not mutually exclusive. You can feel anger in and anger out at the same time, and you can act on them at the same time. Absolutely. So anger and hostility, as again, we covered in your last exam, correlated with negative health effects. But some moderate expression can be good. You know, it's kind of in the balance. So intermittent explosive disorder, we are not talking about people who get angry sometimes and yell. We're talking about people who get angry sometimes and, like, you know, throw the TV against the wall, that sort of thing. That's what we're talking about, right? So people who experience anger tend to rely on projection as a defense mechanism. What does that mean? So basically what that means is they are not necessarily blaming another person or a circumstance or whatever, but they're not really looking internally, right? Because it's too difficult. They just don't have the coping mechanisms to do that. Chronic anger is overstimulating. So I want to remind you that when we were talking about PTSD, we were talking about how those folks that experience PTSD are not always fully present, right? They're kind of going through the world sometimes a little muted. And part of that is part of PTSD is being angry. And so they're a little overstimulated internally. So sometimes engaging with the outside world can be very difficult. Okay, so anger management, catharsis theory. Ooh, bad theory. Okay, so catharsis theory. It's basically like, you know, if you're angry, be angry, throw the mug, like scream at the person. You know, this is kind of the stereotype about New York City. You know, everybody just is kind of going around yelling all the time. No, this doesn't work. Not only does it not work, it actually makes anger worse. A limited expression of anger can be good, but, like, you know, just letting it all hang out is not good. Another approach is stress inoculation. So, you know, what kind of strategies can you use to use in stressful situations so that you actually don't get angry in those situations? That is much more effective because it builds coping mechanisms. All right, a little bit more on anger management. So, passive aggressive behavior. It is a form of anger, you know, being passive aggressive. I mean, that's the aggressive part, right? It's basically resisting expectations of other people and all of that stuff through like just putting it off or pretending it's not happening, or, you know, just saying you're gonna, you know, put up the shelves, and then 2 months later you still haven't put up the shelves, right? That's passive aggressive. Okay. So here are some effective approaches to your own management of anger. And again, these are some of the things that you're using in your wellness groups, right? Okay, depression. So this is my favorite model in all of medicine and psychology. It's used in both medicine and psychology. And if you think about it, it applies to everything. It applies to everything that is an illness that has some sort of, you know, place in your body. So basically what the diathesis stress model is about, aside from its application to depression. So diathesis basically is referring to your body. So, you know, something that's going on in your biology, in your physiology, in your genetics, whatever, that's the diathesis, right? So, you know, if I have, let's say that depression is mediated by 500 genes, okay? And, you know, I have 300 of the 500 genes that you know, kind of push you towards depression. That's your diathesis, right? But if you are stressed out by, for example, being a combat veteran, right, that will bring your ability to use other strengths to kind of push that stress away way down. So, you know, whatever vulnerability that you have in your body, in your physiology, and then whatever stressor on top of that, you know, if you have 500 of those 500 genes, it doesn't take any stress at all for you to end up having the disorder. But if you have 5 out of the 500, it takes a lot of stress to cause that disorder, right? So, you know, if you think about it as a slider, you know, moving across the scale, you know, one gets larger and the other one gets smaller, it still adds up to 100 in the end, right? So I'll see if I can find a video that makes that a little bit clearer. Okay. All right. Yes, major depressive disorder. So obviously we can't cover major depressive disorder in one bullet on one slide, but luckily we have a few more. So lifetime prevalence is 16.5%, not good, right? So again, you know, we're looking at, what is that, 30 some odd people for 200 people. That's a lot. That's a lot of people. So, you know, there are many things that you might be walking around with that increase your chance for depression. Severe chronic medical conditions is certainly one of them. Again, they're talking here about ruminative thinking, pardon me. It will make it worse. It absolutely will. That's a little bit like the obsessions, right? It's another word for obsession, really. So treatments. So the most common are SSRIs. We're familiar with these, you know, the you know, Paxils of the world. But there is a new class of antidepressants, SNRIs, and here are some of them. You probably have heard of Cymbalta. They have a lot of commercials about pain. and Cymbalta, but it's actually an antidepressant. And Effexor, you've probably heard about these other two, Pristiq and Fatima, not necessarily. Okay, so dealing with depression, there's a lot of treatments, but not all of them are more effective than, placebo, really. There are a few. So CBT, again, cognitive behavioral therapy, it is an evidence-based treatment. It absolutely does work. There are behavior modification therapy is what it should say, absolutely does work. So psychotherapy, sort of, right? It sort of works, but what the mechanism for that is not really clear, right? Sometimes people just get better over time, no matter what you do, right? There's a bunch of other reasons, but as with all things, if something is not evidence-based, if it cannot be demonstrated to be effective in comparison to placebo, then personally, I don't put a lot of value in it until that has happened. So general strategies for dealing with depression. Here are some, and some of your papers are about these very things. So, okay, positive mental health, very, very, very briefly. The Diagnostic and Statistical Manual is something we probably all have heard of. It is the main big book of disorders, but there are other ways to classify what's going on with folks, and here are some of those. Okay, so here's a summary. So we talked about fear and anxiety. We also talked about anger and depression. And, again, I'm going to give you a video about the diathesis stress model because I think it's important. And that there are alternatives to the DSM. You are not locked into that. Okay. All right. So thanks for watching the lecture. Please send me feedback if you have it. Ask any questions if you have those. And I will check in with you guys soon. Thank you.